meeting of the Maryland Healthcare. This is a hybrid commission meeting. There are several commissioners here in room 100, and the rest of the commissioners are participating by Zoom. I will read the additional ground rules to apply with a hybrid meeting. I'll begin with a roll call of commissioners. During the meeting, I'll ask commissioners and presenters to identify themselves before speaking so that commissioners and members of the public will know who is talking and have the same knowledge as those of us here in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and presenters mute their electronic devices when they are not speaking. I also ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us here in the room to see the comments. MHCC posts documents that will be acted on or discussed at least a day in advance, so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I'll now call the roll. Commissioner Bhandari.
Here.
Welcome. Commissioner Blake. Commissioner Blake. Commissioner Boyle.
I'm here. Thank you.
Welcome.
Thank you.
I think Commissioner Basinski is a no. Commissioner Basinski? Yep. Commissioner Cheatham?
Here.
Welcome. I see Commissioner Douglas is here. Welcome. Thank you. Commissioner Duncan, Mr. Duncan, I see you on the line there.
Here.
Welcome. Commissioner Gelrud?
Here.
Welcome. Commissioner Gilmore?
Here.
Welcome. Mr. Jensen? I see you there. Mr. Ojikutu? Commissioner Ojikutu? I'm here. Commissioner Spinner is here. Welcome. And Commissioner Wang?
Here, Commissioner Wang's here.
Welcome. Commissioner Wood? Welcome. Yeah, almost the entire commission. Agenda item number 1 is the consent agenda item. The only item on the consent agenda are approval of the March 21, 2024 commission meeting minutes. Does any commissioner wish to discuss or remove minutes from the consent agenda? Hearing none, is there any objection to adopting the items on the consent agenda? Great. Hearing no objection, the consent agenda is adopted. The commissioners have received written updates from our centers. Commissioners, do you have any questions on the written updates?
No.
No questions? Winnie Hawk would like to introduce a new employee. There you are.
Here. Move on and I'll go get it.
Okay. We'll do that. We'll ask the executive director to provide us with any updates not included in the monthly updates.
Thank you. Thank you, Chair Sergeant. I think these are included. I just wanted to highlight them. First off, as I reported last month, the state submitted the AHEAD model application. AHEAD means Advancing All Payer Health Equity Approaches and Development. The state is potentially one of up to 8 states that could be awarded participation in this model. We've been told by the health secretary that planning needs to move forward rapidly with the primary care aspects of our application. So we've already begun meeting with her and her staff to begin to think about how the current primary care model, the Maryland primary care program, evolves should the state be successful in its AHEAD model application. I think in particular, there's interest in the continuing a MDPCP Light program, but certainly given results from the most recent Mathematica evaluation of the total cost of care. There does seem to be still a challenge in the short term in achieving any cost savings under the model. That will be a ongoing concern, and some additional tuning of the financial elements of the model, I think, are probably something we should expect that the state would want to propose in its final approach for the AHEAD if we're successful. AHEAD will start in 2026 if we're successful. As some of you probably recall, the total cost of care continues to the end of 26. So if we're successful, there'll be some standing down probably of the current total cost of care model as we move ahead with the AHEAD model. More to come on that as we move through the coming months. We're very hopeful that the federal government will announce that Maryland is successful when the awards are announced later next month. Also wanted to talk a little bit about legislation today. Tracy DeShields is not able to attend, so we'll defer the primary legislative update on the 2024 legislative session until May, but I wanted to highlight the three bills that we had really paid much attention to and devoted considerable effort to. The first one is the nursing home acquisitions legislation that passed both House and Senate, has not yet been signed by Governor Moore. The prospects are probably pretty good that he will sign those, but it is the governor's decision. That requires any acquisition activity defined as a change of ownership on 25% or more of a nursing home has to 60 days prior to the acquisition closing, submit an application to the Healthcare Commission. The Healthcare Commission would review that application, judge it suitable for final review. At that point, it's the discretion of the executive director to determine whether the application for acquisition should be approved with conditions, or denied, or referred to the commission, the full commission, for consideration. The commission should the director take that course, the commission itself in public session would act on the acquisition. And again, those three options would be available: approve with conditions, or deny. Like all MHCC actions, should the applicant be dissatisfied, typically that would be a denial. They do have access to the court system to appeal that decision. We are required to develop regulations before this legislation takes effect, and we're directed to have those regulations in place by the end of 2024. So quite a bit of work yet. Fully blowing out the process for that will wait until Tracy comes back. I expect that Tracy and Winnie Hawk, who heads up, that's the center responsible for this new responsibility, will provide a more detailed review of that. The second piece of legislation is the modifications to the trauma program that entailed quite a bit of activity throughout the legislative sessions. A number of bills were introduced. Ended up that there are actually three pieces of legislation. The two bills that each one of which originated in the House, one of which originated in the Senate. There was some concern about whether this would actually see action. So the language was also inserted in Senate Bill 362, which is called the Budget Reconciliation and Financing Act. It's sort of this catch-all piece of legislation that does typically reallocate certain state budgets, but also can have some statutory language, and it does address the trauma system as well. The trick is that these generally align, the three bills generally align. There is one difference between the House and Senate bill, and that is on how much the assessment on motor vehicle fees would be devoted to the Maryland Trauma Physicians Fund. In the Senate, it's $750 going up from $250 today to $750. In the House version, and in the BRFA, the Budget Financing and Reconciliation Act, it's $650. Both of those are sizable increases. Keep in mind that we do the registrations, we do it on a biennial basis. So this is going from when we renew our license, $5 of that is devoted to the Maryland Trauma Physicians Fund. Should the governor sign this legislation, it would go from either $13 or $15 per automobile registration. The legislature was pretty cautious about new taxes, but I think the challenges in the trauma and emergency healthcare system generally were found to be compelling, and this legislation passed. We'll have to sort out with the legislature and the governor's office, whether the funds for trauma physician fund are going to increase by basically about $15 million or closer to $22 million. What that will mean is that the commission itself will have greater responsibility for distributing these funds. We were also given authority for expanding the grant program. Historically, it was called the Trauma Equipment Grant Program. The term equipment was struck so that it gives us more flexibility, potentially to cover not only equipment, but certain education, training, and trauma education activities as well. But again, as you're going to see when the full presentation is, the legislature has a lot of confidence in this commission, and typically gives us new responsibilities, and they did so with this bill. Lastly, the
One question, Ben.
sure.
With the administration of the trauma fund, are there things that we're looking at doing or can do that relate to emergency room wait times reduction? Is that a completely separate issue?
I would say that's a completely separate issue from the standpoint of how the executive branch is choosing to address it. There is another emergency department wait time commission, of which the healthcare commission is to be a member of that, but I think the trauma fund I see is independent of the wait time issue. Generally, keep in mind that at the 10 trauma centers that are designated by MIMS, trauma is always kind of jumping the line. If there's a trauma case and you're a trauma hospital, you don't ever go on yellow alert and divert that trauma patient to the next trauma center, which could be some miles away. Trauma is not subject to the yellow alert rules, in which a trauma center, an emergency department would say can't take any more calls. So it's exempt from some of the challenge, some of the restrictions, but certainly could be affected at a community hospital by a very crowded emergency department. The other piece of legislation I wanted to talk about is one that Teresa Lee and her staff have paid attention to, and that is House Bill 1051. This was introduced by Delegate White from Howard County. She is also works with Horizon Corporation, but House Bill 1051, maternal health assessments, referrals, and reporting. Does add additional, formalizes some reporting requirements that have been in place, but puts them in under statutory umbrella. It also requires the MHCC, the health department in collaboration with MHCC. It does have meeting collaboration as opposed to lead, and we are to collaborate with the department in developing a birthing center report card, which kind of caused me to pause because birthing centers, there aren't a significant number of freestanding birthing centers, but of course, most every hospital, not all, have obstetrics programs, and they would be the subject of largely of this new reporting initiative. Even before the bill has been signed, Teresa has organized a meeting with some of the staff that will be working on this from the department, and we're excited to get this underway. Lastly, kind of a bill that we had not been monitoring. I was aware of legislation that had been introduced regarding non-compete clauses and had been told that there might be something gift in there for MHCC. And indeed there was in the uncodified language. The Healthcare Commission is directed to award a contract to a private consultant to study the effect of private equity on the healthcare marketplace in Maryland, including the impact on the ability of the state to meet the total cost of care goals, the impact on state's ability to reduce health disparities, the impact health equity has on the payer mix for physician practices, the impact of hospital consolidation on physician practices, and the consequences of health equities or private equities acquisition of physician practices and ambulatory surgery centers broadly. So this has to be done by December 1st, 2024. So assuming the governor signs this, we're going to have to move pretty rapidly forward in implementing those requirements under the law. It parallels in some respects the work that we've done over the last year and a half on nursing home acquisitions, where again, private equity was oftentimes pointed to as the need, a reason for MHCC to play a more direct and active role in nursing home acquisitions. It looks like there's similar interest in other aspects of healthcare. I would add, however, that I think private equity is a concern, but the issues related to health system, it's largely hospitals and health payers acquiring physician practices is an equally big concern. We know from the research literature that although health systems oftentimes make the argument that there's efficiencies and savings, a variety of researchers from numerous institutions, at least in the short term, have not been able to identify significant savings. And in fact, many point to additional costs. Our own colleagues across the way oftentimes note that many hospitals have challenges meeting total cost of care objectives because of the cost of Part B subsidies, meaning that they are oftentimes forced to backstop physician practices that they own because the practices are not generating expected revenue. As most of you know, Maryland, for a variety of reasons, is a state where physician compensation tends to be a bit lower, consistent with what we see across the entire Northeast. Physician compensation is lower, but it certainly has been a mixed bag, I think, for many health systems for physician to acquire physician practices. Many report they're not really generating the cash returns that they thought. So definitely of interesting study, and I know a number of commissioners are very interested in this topic, and more to come on this moving forward.
One question on the report, we're hiring a consultant. Is this the MACC presents a report that a consultant is prepared to serve the industry, or are these supposed to wind up being an MACC report with recommendations?
It's an MHCC report with recommendations.
I
I
see.
think, I mean, typically that would be the expectation of the legislature. I
Going to need enough time in the fall then, because it's a complicated area. We haven't delved into it deeply before, and commissioners may not all agree.
I expect that is a prospect of.
We should just make sure we have enough time in the fall.
Lastly, I wanted just to remind the commission, we will be getting some new assignments. I'm going to leave that to Tracy to tell you about it, but just to kind of give you an update of what you might expect later on this fall already in terms of studies that we have to do. There are two that were assigned to us regarding payment levels for behavioral health services and telehealth adopted in the 2023 session. That is going well. It's done under the direction of David Sharp with a Milliman Consulting helping us with that. We are also working on a behavioral health workforce assessment that Tracy Shields is leading that effort. And we have a small contractor who's done similar work, California, assisting with us as well. We also will be issuing the second report on the primary care investment work group. That's going to be largely a homegrown MHCC generated work. And that is due again on December 1st. We will also have our typical trauma fund reports that we do issue on, I think it's due November 1st. There'll be more interest in this year because it will be the first trauma spending report after this passage of this legislation. So there'll be interest in just where things stand. And lastly, we have one remaining, I guess I call it quasi mandate study, which is to examine the impact of biomarker testing for certain cancer conditions. That's a retrospective study. The legislature passed a mandate for biomarker testing in 2023. They want MHCC to look back on what the cost, impact, and outcomes were of allowing this. And lastly, I wanted to just note that the Healthcare Commission has awarded a contract to Friedman Health, a small Boston-based consulting firm that is helping us with the project management activities and analytic activities pertaining to the APCD. It's a 7-year contract for $4.3 million. I want to note Ken Yates Trotman really did a great job of shepherding that procurement through a number of hurdles that we had to face, and it's now in place. And we had our kickoff meeting yesterday. That's good news because Friedman is doing a lot of good work for us as well. And lastly, the long-awaited redesign of the MHCC website, again, done under contract with Breakthrough Technologies out of Chicago. That's slated to start tomorrow. That concludes my update.
Were there any questions? Not, Winnie, I'll turn you back to the floor. I understand you have a new employee you want to introduce.
Yes, thank you. I'm sorry about the hiccup at the beginning, but I'd like to introduce everyone to Deanna Dodd. As many of you know, Ruby Potter is retiring after many, many years, but I think we're in capable hands. Deanna comes from the State Department of Assessments and Taxation, and before that, the Maryland Department of Health. She was in Medicaid recovery, so she has history with our department. She has a Bachelor of Science in Computer Engineering, a Bachelor of Arts in Health Sciences, and a Master's in Human Resources. So I think Deanna is like the perfect person to keep this. She's going to be the train conductor in my center to keep us moving. I think in her prior jobs, she has She's been shown a lot of competence in interpreting regs, which is, we are a regulatory intensive center, well, agency altogether, but I'm really pleased to introduce you to Deanna. First day was yesterday, so.
Welcome. All right, with that, we'll turn to agenda item number 3. The next agenda item for consideration is a certificate of ongoing performance application. MedStar Southern Maryland Hospital Center to continue providing both primary and elective PCI services. An overview of the standards that apply and staff's recommendation presented by Elliot Burkham, Program Manager for Acute Care Policy and Planning Team. Before we turn the floor to Elliot, though, I do want to say there are some confidential information on each one of the next 3 applications. If anybody asks about or discusses that, we will go into closed session. So there may be just for the commissioners on Zoom, we'll have instructions on, we will leave the room, we will break out on Zoom, and there will be sort of some steps. So if folks ask about the confidential information, we'll kick that process off. So I just didn't want anybody to be confused if they ask a question, all of a sudden we're like, okay, everybody move. Like that's what's going on. So Elliot, you have the floor.
I'm Eileen Fleck, the Chief for Acute Care Policy and Planning. I just thought before Elliot got started, it'd be useful to provide a little bit of history. I know this is new for many of the commissioners here.
Sure, go ahead.
For many years, only hospitals with cardiac surgery on site could provide primary PCI services. But in the late 1990s, hospitals without cardiac surgery were allowed to participate in research trials to evaluate the safety of primary PCI at hospitals without cardiac surgery. Based on those research findings, MHCC began issuing waivers to hospitals in Maryland to provide primary PCI services, even though they didn't have cardiac surgery on site. There was another study, the Seaport East study, that began looking at elective PCI services. Many of the Maryland hospitals participated in that research study. And again, as a result of the findings, there were waivers issued, so that would be possible. And then based on the findings of those research studies, MHCC decided that it was important to move towards having ongoing, make this something permanent. There was a law that was passed that led to statutory changes to establish the certificate of ongoing review process. And that included the directive for MHCC to establish regulations in this area, which we did.
Good afternoon, Chair and Commissioners. So MedStar Southern Maryland began providing PCI services before August of 2014 under the waiver that Ms. Fleck just mentioned, and was not required initially to submit an application for a certificate of ongoing performance, but they did so in September of 2019 due to a lack of MHC staff resources and the need for a focused review, which we'll mention later on. There were some gaps in processing the application, and we are now ready to proceed with our recommendation. We can go to the next slide. So this summarizes just the basic categories of requirements with which PCI programs in Maryland must comply. We can go to the next slide. It's very important that primary PCI services are available at all times to provide potentially life-saving treatment. And to that end, MHCC regulations require that primary PCI services be available 24/7. MedStar Southern Maryland submitted documentation indicating that at no time between 2015 through 2023 were any downtimes in the facility's cardiac cath lab sourced that would prevent the delivery of primary PCI services at the hospital. Door-to-balloon times are also critical for PCI services to be provided as quickly as possible to ensure better outcomes for patients. The standard is that in 75% of non-transfer primary PCI cases, the door-to-balloon time has to be 90 minutes or less. Over the 8-quarter rolling 8-quarter periods during the review period, this hospital complied with that standard, never having fewer than 75% of their non-transfer primary PCI cases having a door-to-balloon time of 90 minutes or less. There are also regulations that relate to the adjusted mortality rate or the RAMR. And the commission has a requirement that hospitals should maintain a risk-adjusted or mortality rate consistent with high-quality patient care. The commission has interpreted that requirement to mean that the facility's RAMR must not be statistically significantly different than the national benchmark that's established by the NCD-RCAF PCI registry. The hospital performed similarly, was not different from the national benchmark for nearly all of the 12-month periods from 2015 through 2023, except for 3 periods which necessitated a focused review. And we can go to the next slide. So this slide is displaying the national benchmark and then the hospital's performance, and of course indicates that generally the hospital met or exceeded the national benchmark. There were these 3 periods in 2019 and 2020 where the hospital did not achieve the standard and necessitated the focused review. As was mentioned before, the focused review is confidential. That was provided to the commissioners separately by email. So we're not going to get into those details, but what we can say very broadly is that the focus review did indicate a need for some improved record keeping by the hospital during and immediately after PCI procedures, particularly as that record keeping related to the administration of medications. The hospital and MHCC met in November of 2023 and reviewed the focused review, the findings, and the hospital provided MHCC with written corrective actions to address the issues noted in the focused review. And those written corrective actions more or less constitute the conditions that we suggest the commission impose on the issuance of the certificate of ongoing performance. And that condition will be discussed in greater detail later on. If there are no questions, we can go to the next slide. This slide indicates that the hospital consistently met the standard for non-STEMI PCI cases throughout the review period. I should note that while these slides have the data for 2019 through 2023, in the full report that was provided to the commissioners, we did present and review data going all the way back to 2015. And we can go to the next slide. There's a requirement that hospitals demonstrate that they're taking appropriate action in response to concerns identified through quality assurance activities. The hospital provided descriptions of the steps it was taking to ensure that high quality care is provided to all PCI patients. I would emphasize this is both in response to the focused review and not. The hospital had ample quality assurance activities in place even prior to the focused review. We are recommending that the commission find that the hospital meets the standard, again, with the condition that it continues to implement the corrective actions it developed and provided to us in writing in response to the focused review. Again, will be discussed in greater detail momentarily. We can go to the next slide. Case volumes are very significant with respect to PCI programs because research has demonstrated that operators provide higher quality care when they practice with greater frequency. And that's true not only to the individual physicians, but to the systems as well. So we require that PCI programs maintain a basic case volume per year. The requirement is that the facility complete 200 cases annually of any type of PCI. MedStar Southern Maryland met that standard by never performing fewer than 310 cases in any of the years in this review period. There's an additional requirement that hospitals complete 49 primary PCI cases per year. And again, MedStar Southern Maryland met that requirement, never performing fewer than 115 primary PCI cases in any year during the review period. External review is also a critical element of a high-functioning PCI program. The hospital met the requirement for a semi-annual external review of at least 5% of its randomly selected elective PCI cases by working with MACPAC. MACPAC is the Maryland Academic Consortium for Percutaneous Coronary Intervention Appropriateness and Quality. And the MACPAC reports reviewed always 7% or more of the hospital's elective PCI cases. important to note that in addition to the program-wide requirement of 5%, there's also a physician-specific requirement of at least 3 cases per operator, or all cases if the operator only performed 1 or 2 cases. And the MACPAC reports indicate that the hospital met that standard as well. With respect to the second standard that all, not only elective, but all PCI cases be reviewed, 10% of all cases per operator be reviewed, or all cases if the operator did fewer than 3, the hospital met that standard through a combination of the MACPAC reports that we just mentioned and its own internal case review process. You can go to the next slide. Hospitals are required when providing PCI services to have a formal process for interventional case review that includes regular meetings that occur at least every other month. Documentation was provided that MedStar Southern Maryland has interventional case review meetings at least every other month. The meetings did include both physicians and nurses. Unfortunately, did not include, MedStar Southern Maryland was not requiring its technicians to attend the meetings. A regulation does specifically call out technicians, so we will be including a condition on the proposed approval of the certificate of ongoing performance that the hospital start requiring its technicians to attend its interventional case review meetings. There's an additional requirement with respect to meetings that a hospital create a multiple care area group. That includes the physician and nursing leadership of each of the care areas involved in the provision of PCI services. And that care group is supposed to meet monthly. MedStar Southern Maryland provided documentation that its multiple care area group was meeting monthly during the review period. There were a small number, approximately 6 meetings whose documentation was lost, probably due to a software error, but in general, all the documentation for the rather large review period was available to us. Meetings were held monthly throughout the entire period, with the only exception being April of 2020. The hospital's COVID protocol requiring that resources be directed elsewhere. There's a final requirement or standard that primary and elective PCI is only provided to suitable patients. The MACPAC reviews largely focus on whether a PCI was the appropriate medical intervention to give a patient. And the hospital's results were that no cases were determined to be inappropriate or even rarely appropriate by 2 or more of the 3 different criteria that are used to evaluate appropriateness for PCI. We can go to the next slide. Ultimately, in light of all the facts that were gathered, staff recommends that the commission issue a certificate of ongoing performance to MedStar Southern Maryland Hospital Center, which would permit the hospital to continue providing primary and elective percutaneous coronary intervention services for 4 years, subject to the following 2 conditions. Please go to the next slide. Number 1, we're asking that the hospital demonstrate that the documentation of PCI cases is accurately capturing all patient care through the following. Number 1, the hospital is going to provide MHCC staff with a copy of its revised training materials for its cardiac cath lab staff, which materials are specifically aimed at ensuring proper documentation during all cardiac cath lab procedures. And we're asking for that documentation on or before May 31st. We're asking the hospital to provide MHCC staff with records of which cardiac cath lab staff have undergone the revised training and the dates. And again, we would like that documentation on or before May 31st. The MedStar Southern Maryland should provide MHCC staff with documentation of the findings from its random monthly documentation audits for the period of October 23 through March 2024, and any actions that were taken to resolve issues identified through those audits. Again, we're asking for that documentation on or before May 31st. I should reiterate that the majority of these action items, not the date of May 31st, but these actions are all things that the hospital itself suggested in its proposed written corrective actions in response to the focused review. And then finally, we're asking the hospital to complete additional auditing of its documentation for PCI cases, even after May 31st, if MHCC sees a need to request such additional auditing, and then report its results to us within 30 days of the end of the audit period. Are there any questions about condition number 1?
Any commissioners have questions?
Sorry, there's condition 2 also, a proposed condition number 2. Okay, we can go to the next slide. And then secondly, we're asking for a condition that the hospital demonstrate that its bi-monthly interventional case review meetings will include technicians, and they're going to submit to the commission its attendance lists for the case review meetings. So for the meetings between May and October by December of each year, and the meetings between November and April by June of each year, until December 1st of 2025, and after that date, the executive director may release MedStar Southern from the reporting requirement if it's determined that the hospital has achieved substantial compliance with the condition. I should mention that MedStar Southern Maryland has representatives available both in person and online if need be. Joining us from MedStar Southern, we have Dr. Gotu, who's MedStar Southern Maryland's Vice President of Medical Affairs, Dr. Taylor, MedStar's Chairman of Cardiology for its Heart and Vascular Institute, Dr. Case, MedStar Southern Maryland's Director of Interventional Cardiology, Kristen Quaid, the Senior Nurse Director of Operations for Cardiovascular Services, and Mr. Keith Baker, the Interim Cardiac Cath Lab Director for MedStar Southern Maryland. We're prepared to address any questions if there are any.
Are there any commissioners that have questions? I approve today. We do this, see if we have any discussion, but first, can I get a motion to approve the MedStar Southern Maryland COP for PCI?
So moved. Second.
Commissioner Jessen, and I have a second. Commissioner Douglas. Are there any commissioners that want to discuss or had any additional questions? Okay, that, are all in favor? Aye.
Aye.
Are there any opposed? None opposed? Motion passes. Thank you.
I'd like to thank the MedStar representatives for making the trip.
Oh, yes, I apologize. It's sort of my job. Thank you. Thank you for coming in.
Well done.
Apologize. Let's think, going on to number 2. Agenda item 3B is a certificate of ongoing performance for cardiac surgery services at Frederick Health Hospital, COP for PCPI. The next agenda item is an application for certificate of ongoing performance for PCI services at Frederick Health Hospital, which provides both primary and elective PCI services. A discussion of the state health plan standards that apply to the application and staff recommendation were presented by Katie Nerrell, program manager for the acute policy and planning team. Katie, you have the floor.
Thank you, Mr. Chairman, and good afternoon, commissioners. Frederick Health Hospital, formerly Frederick Memorial Hospital, is a general hospital located in Frederick County, Maryland, that provides both primary and elective PCI services. The hospital began providing primary PCI services in March of 2008 under a waiver, and a year later in March 2009, the hospital was granted a waiver to begin providing elective PCI services. These waivers were needed because the hospital does not have a cardiac surgery program on site. And as Eileen discussed at the time, only Maryland hospitals with cardiac surgery on site were permitted to provide PCI services. Maryland replaced the waiver system with certificates of ongoing performance in 2012. The law establishing certificates of ongoing performance also permitted existing programs to continue to operate without one until the application of the hospital is considered. Today will be the first time the commission has considered granting Frederick Health Hospital a certificate of ongoing performance. Next slide, please. So on this side, you can see a summary of the service standards that have been established by the commission for a certificate of ongoing performance for PCI services. Standards relate to data collection, institutional resources, quality, patient outcome measures, physician resources, volume, and appropriate patient selection. Let's move on to the next slide to look at Frederick Health Hospital's compliance with these standards over the period from approximately calendar year 2015 through calendar year 2022. So on this slide, as you can see, the hospital has met the requirement that primary PCI services be available 24 hours a day, 7 days per week, with one exception during the review period. This exception was due to unavoidable circumstances. Specifically, an unexpected repair of the HVAC system contributed to the downtime of both cardiac catheterization laboratories for a 24-hour period. However, no STEMI patients presented at the hospital during that time. Over rolling 8-quarter periods, you can see that Frederick Health Hospital complied with the door to balloon standard of 90 minutes or less for at least 75% of primary PCI cases. Between 89.3 and 95.3% of non-transfer PCI cases had a door to balloon time of 90 minutes or less in each rolling 8-quarter period from Q4 of 2016 through Q4 of 2022. For the risk-adjusted mortality rates, or AMR, over rolling 12-month periods, the hospital performed similarly to the national benchmark for STEMI and non-STEMI cases for all periods from January 2019 through September 2023, except for the 12-month period ending in June of 2020. The hospital also met the benchmark for all earlier reporting periods, going back to calendar year 2015. Although the standard only became effective in January of 2019, excuse me. Next slide, please. As you can see, Frederick Health Hospital's adjusted mortality rates by rolling 12-month period for STEMI cases met the standard in all periods, which means that the hospital performed similar to the national average in all 12-month periods. We can move on to the next slide, please. So this slide shows the hospital's adjusted mortality rates for non-STEMI cases. Yes.
So it'd probably be good, since this is the first time we've ever done this recently, to explain how we interpret the hospital adjusted mortality rate relative to the confidence intervals. I think it's intuitively obvious to a lot of people, but let's be sure that we understand those two columns, what they mean.
Ben, I was just about to do that. Okay. So on this slide, we can see the hospital's adjusted mortality rates for the non-STEMI cases over rolling 12-month periods. And as you can see, the hospital did not meet the standard for the period from July of 2019 through June of 2020, because the hospital's mortality rate was statistically significantly worse than the national benchmark. And staff was able to draw this conclusion because the hospital's 95% confidence interval for this period does not include the national benchmark. And the entire range of values included in the confidence interval is greater than the national benchmark, which means that the hospital's mortality rate for this period triggered a focused review because it fell outside of the confidence interval. Did that work, Ben? Okay. So
That means the mortality rate, that's the range in which we're 95% confident the actual mortality rate falls.
correct. And so if the national benchmark falls outside of that, you're either better or worse than statistically than the national average.
Can I ask a question about the previous slide with asterisks? I think this was in the
Can we
material.
go back one slide, please?
Did the standard change? Because I saw this in the previous one, right? There's for mortality, the national benchmark for mortality is at 7s and 6s at the bottom, and then at the top it's markedly lower. And the hospital's performance is lower. It looks like, did the standard of measurement change? Because both columns are affected.
So the reason that I put those asterisks there, and I think it has this note in the table in the report, is that there was a change, and the cases with cardiogenic shock, which are very high risk for death, are not included anymore. It was seen as a concern in terms of being fair to hospitals, not being able to risk adjust enough, being really even in the way that we're looking at it by not having those cases, separating them out. There is an overall metric for all the cases just together that would include them. So that's why I thought there should be an asterisk indicating that, yes, it did change in terms of what's in the report and actually what's included in the measure.
Okay, but we're comparing the hospital adjusted column to the national benchmark column, and they both changed together.
Right, they both changed together. And we did look at how many deaths there were by subtracting out, right, the ones that were included in STEMI and non-STEMI and overall. And it didn't look like, oh, there's a bunch of patients with shock that were not included, and that really skewed anything. So.
Back to the next page with the red line on it.
Yes, so if we can jump forward, and I think if we can go to the next slide then as well. Thank you. Okay, so for the focused review, MHCC staff contracted with an organization who had an independent board-certified interventionalist review the non-STEMI cases with mortality during the period from July of 2019 through June of 2020. This interventionalist was also asked to address whether the hospital responded appropriately to issues identified. A total of 7 cases were reviewed. Details of this focused review are considered confidential and are not available to the public, but commissioners can ask for more information from staff or representatives from the hospital in a closed session following this presentation if needed. So after receiving the focused review report, the hospital explained steps that it had previously taken beginning in March of 2020 that addressed a key concern that was identified. A formal written response was also provided by the hospital that addressed all of the recommendations from the report. Because Frederick Health Hospital has already taken action to address concerns raised in the focused review, and based on the hospital's acceptable performance for the mortality metric for non-STEMI cases since the period ending in Q3 of 2020, staff recommends the commission find that Frederick Health Hospital complies with this standard. Next slide, please. So the PCI program performed over the target volume of 200 cases annually. As you can see, the volume of PCI cases ranged from 383 to 465 cases annually between calendar year 2015 and calendar year 2022. The volume of primary PCI cases was also greater than the 49 cases that are required annually for rural programs, ranging from 87 cases to 137 primary PCI cases annually for the same period. Between 7.7 and 13.3% of elective cases went through external review each calendar year, exceeding the 5% required. The reviews are completed by the Cardiac Community Core Lab, or CCCL, and took place semi-annually from calendar years 2015 to 2022. At least 3 cases were reviewed every 6 months for each interventionalist, unless fewer than 3 PCI cases were performed, with one exception. During the period between July through December 2022, only 2 cases were reviewed instead of 3 for one physician. The hospital reports that in this instance, the 3rd PCI patient was inadvertently left off the blinded list sent to the CCCL due to the case being incorrectly classified as emergent in the hospital's internal database. Because this was minor and unintentional, staff recommend that Frederick Health Hospital be found to be in compliance with this standard. In addition to the external reviews that are completed, Frederick Health Hospital reported that internal review also takes place through 2 modalities, with all of the PCI cases being reviewed quarterly. The reviewer uses angiographic images, medical test results, and the patient's medical record to determine the appropriateness of each case. Next slide, please. So the next standard requires the hospital to hold interventional case review meetings at least every other month. And these meetings should include physician and nurse leadership from each area that cares for the primary PCI patients. From calendar years 2015 through 2022, either 11 or 12 meetings were held each year, with the exception of in 2021 when only 9 meetings took place. PCI programs are also required to hold monthly multiple care area group meetings to discuss potential improvements to the process of identifying and treating STEMI patients. These meetings also took place regularly during the review period, with few exceptions. And an external review of PCI cases also indicated that PCI was appropriately provided with the cases that they reviewed. Next slide, please. So with that, MHCC staff recommends that the commission find that the hospital has complied with all standards and approve the certificate of ongoing performance to allow Frederick Health Hospital to continue providing primary and elective PCI services for the next 4 years. With us today is Kristen Deely, Director of Cardiac and Vascular Services, and Dr. Kathy Weichar, VP and Medical Affairs and CMO for Frederick Health Hospital, as well as Elizabeth Keenan, attorney with Miles and Stockbridge. Attending this meeting virtually, I believe, are Cheryl Kofi, Senior Vice President and COO, and Dr. Chao Wei Huang, Co-Medical Director of Interventional Cardiology for Frederick Health Hospital. At this time, I'm happy to take any questions that you may have.
Are there commissioners who have questions? I have questions about the confidential part of the report.
Okay.
I think it's something that we should discuss as commission. I'm not sure if I need a second for a chairman's motion to go into closed session, but I will make a motion to go to a closed session.
And I'll second.
Okay, I got a second from Commissioner Jensen. So this will entail some movement on our part as we get set up a different way, and I have to read a little introduction. Well, actually, when I take a vote, all in favor of going into closed session?
Aye.
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 Are there any opposed? Thank you. Sorry about that. I haven't done this part. So our meeting will be moved into a closed meeting. Before we move into a closed session, I have to give the following statement. This meeting will be closed under General Provisions Article, Section 3-305B13, to comply with a specific constitutional, statutory, or judicially imposed requirement to prevent public disclosures about a particular proceeding or matter. Under Health Occupations, Section 1-401, the proceedings, records, and files of a medical review committee are confidential. In addition, the commission is engaging in a quasi-judicial function when it decides on an application for certificate of ongoing performance. Under General Provisions 3-3103, the Opens Meeting Act does not apply when a public body is carrying out a quasi-judicial function. The meeting will also be closed under General Provisions Article Section 3-305B7 to consult with counsel to obtain legal advice. We will be discussing the focused review findings of Frederick Health Hospital. Specifically, we'll be discussing questions about the confidential portion of the focused review. The commission serves as a medical review committee when it or its contractor conducts a focused review, and these discussions about the review must be kept confidential. In addition, the commissioners may have questions for the commission's assistant attorneys general about MHCC's options. After this discussion is complete, we will return to the open session to finish the rest of the agenda items. That's it. So for the commissioners, we will adjourn to the next room. The public can stay here. And those online will have breakout rooms for you. So you can join us.
Thank you.
So folks that are not affiliated with Frederick that are in attendance can wait briefly. And we'll resume the public portion of the meeting at the conclusion of the closed session. So.
Okay, we're just right here. You can wait here. We're just coming right.
Okay, great, thanks.
Anybody wanted to know that they wanted to. If you find out otherwise. Happy to do whatever.
That sounds like worse. I do too. Thank you to join us. Okay. That was more complicated than you think. I just wanted to together decide.
Commissioner Wang, are you still on the call connected by your phone? It may not be. I know that I sent him a message. Yep.
I don't see him on here.
I could have sworn that, no, he's not. He's not on.
Nope. I don't see no phones on.
Yeah, there's nothing I can do. Yeah, unfortunately, there's nothing I can do with that.
We do have a subway, but don't. It's that long together. Well, he did that all the time. He wore that. Oh.
I didn't even get out of the train.
Yeah.
He was there for 3 summers. I like it. I was there like every other day. I loved. Yeah. Guys. Other great fun. Yeah, I was one. Yeah.
Yeah. I am there. We just made it happen. Oh, yeah.
This is something that. Also, they're existing.
Also, we try to get a lot of our work. Private equity. Well, they also do the. That's awesome. And I worked here before. And like, when we were so 3 hours. Oh, yeah, it was pretty interesting.
Like buy in.
Yeah, more efficient. Like it's a little bit like a. Child here, wow. Oh. Yeah, like on the other ones, like. You know. I'm a little witty sometimes, I don't need to be witty. You're right. Every time. Yeah. Yeah. Sure. No, I have to look at her, she wanted.
Sure. All right.
Half a day, half a day. Like, it's terrible. Yeah, it's like, and then it's when I was on vacation. And I'm having sections of them. Now I take. Okay. It's very important, I think. That's having a lot. I also. Reason why is I did. I know what I did. I know. Well, these. We're back into the main room. Oh, she got. Or even I accidentally. It's wearing them for her present. She's a heavy. You know. I mean, not exercise. Nice, or anxiety, it's like, it's graduates. Round on the board, oh, she's like. At least it's. Yeah, maybe. Copy of police. Yeah, I know, it's only 45 minutes. My mattress is your best friend. Yeah, he's the bottom out. Oh, I haven't thought about it. My glasses. Yeah, we did. We were in it.
I'm on the other side.
Yes. Then my. That's a big part. All on one page, I'm like, oh, I guess that's narrated, yeah. Another perspective. But it keeps. The leader is good or bad? Yeah. Listen, I know I'm an empty answer. Love it. Although the senior. For sure. Yeah. That's the hardest. Yeah. Hands down. No, this is very cool. I love it. I love it. You're right. It'd be hard. Yeah, that's probably. I know it is, yeah. And it can help. Yeah. Right. Yeah, it's gonna be. Yeah. Billy. Their volume is probably like a. That's that guy. Yeah. That's what it's
I have.
That's how they read it.
Probably like, oh, it's just.
Jill. Nice to meet you. I think that's it.
Actually.
Right. Yes.
Ready?
That,
I need to read the start again.
I don't think so. I think you can just go to vote, but Commissioner Wang did text me that he had to jump off.
Okay. Thank you. We have our other online commissioners. I see Commissioners Duncan and Bendari. So it's- We need to make a, we need to close. Get back to my page. So we are back on the record. We have had our closed session. The minutes can reflect a robust discussion focused on the purpose of the closed session. And with that, I'll ask the commission, can I get do a motion, and then if there's any other public discussion or questions, do I have a motion to approve the Frederick Health Hospital COP for PCI? Thank you, Commissioner Gilbert. Do I have a second? Second. Thank you, Commissioner Douglas. Is there any open session discussion that anyone wants to have? Or questions? Great, with that, all in favor?
Aye.
Are there any opposed? Motion passes. Thank you.
Could you on the line, indicate, I didn't hear you, raise your hands if you, or, approving motion?
It's Commissioner Duncan, Commissioner Blandari.
Thank you.
And
Thank
Commissioner
you.
Gilmore.
Gilmore,
There you go.
thank you.
Thank you all. Great, the motion passes. Thank you for coming in and speaking with us.
Thank you.
With that, we could go into agenda item 3C. The next agenda item for consideration. The next agenda item for consideration is Sinai Hospital's application for a certificate of ongoing performance for cardiac surgery services. Eileen Fleck, Chief for Acute Care Policy and Planning, will present an overview of the staff report and recommendation. Eileen, you have the floor.
Good afternoon, Mr. Chair and Commissioners. Sinai Hospital established its cardiac surgery program in 1990 through the CON process. Several years later, as we've talked about, a law was passed that established the Certificate of Ongoing Review process. It took a few years to establish the regulations for that. As a result, the first time that any cardiac surgery hospital was expected to apply for a certificate of ongoing performance was April or May of 2017. This hospital has received its first certificate of ongoing performance in May of 2019. That was awarded for a period of 4 years. We did need to extend that certificate of ongoing performance for almost a year now so that we could finish the focused review and bring this to you. So this is the second time the hospital is applying. It applied in September of 2022. On this next slide, there are the key standards that are part of the certificate of ongoing performance for cardiac surgery hospitals. In terms of data collection, the hospitals need to participate in the Society of Thoracic Surgeons Adult Cardiac Surgery Data Registry. Participation in that registry allows hospitals to receive feedback on their performance that accounts for patient risk and other detailed information. It's also what MHCC relies on to get a sense of the performance of the hospital. The second standard on here pertains to quality. The hospital must commit to complying with requirements for quality assurance activities, including internal and external peer review of cases. Unlike the PCI programs, the cardiac surgery programs don't have to do mandatory external review routinely. However, they do have to engage in peer review processes and are expected to demonstrate that they've taken appropriate action in response to concerns identified through their processes. Next on the slide, we have performance standards. There are specific performance standards that hospital needs to meet. The STS registry has a star rating system. It's a 3-star system. Most hospitals receive 2 stars, which indicates good performance that's similar to the average for participants in the registry. Less than 10% of programs receive either 3 stars, indicating that they're the very best programs, or 1 star, indicating that they are a poor performing program. Our regulations state that if a hospital receives 2 1-star ratings in a row, then we will do a focused review. And if a hospital were to receive 4 1-star ratings in a row for that composite measure of CABG cases, then it would be evaluated for closure. Our regulations also state that a hospital needs to maintain a risk-adjusted mortality rate that is consistent with high-quality patient care. We rely on information from the STS reports and information provided from STS directly to MHCC to evaluate that. The last standard shown on the slide is volume requirements. There is an expectation that hospitals maintain a volume of 200 or more cardiac surgery cases. That standard was set based on research that shows a higher volume program tends to have better patient outcomes and is higher quality. Although we have that expectation for hospitals, it's only if a hospital falls below 100 cases for 2 years in a row that it would trigger a focused review. Another key element that I want to mention, which is not on this slide or emphasized in the report, is that there was a law passed in 2014 that requires a hospital with a cardiac surgery program to agree to voluntarily relinquish its authority to provide cardiac surgery if it does not meet the requirements in a certificate of ongoing performance and has been given an opportunity to correct deficiencies and fails to correct them. As part of the application process, the hospitals do have a designee sign an affidavit saying that they will follow that law. Next slide. On this slide, I have some summary information in terms of our assessment of the hospital. As I just mentioned, a hospital needs to demonstrate that it's taken appropriate action in response to concerns identified. Sinai Hospital explained its quality assurance process to us in detail, provided meeting minutes and examples of quality improvement initiatives. It also provided detailed information on how it addressed concerns that came up in our focused review for the CABG cases with mortality in calendar year 2019. For the next standard here, the STS composite score for CABG cases, during the period January 2018 through June of 2023, the hospital received 2 stars in all periods. That means that it's a good performing hospital, similar to all the other programs that participate in the STS registry. That composite metric has 4 components that include the absence of operative mortality, the absence of major morbidity, use of the internal mammary artery for bypass graft, and perioperative medications. For half of these reporting periods, it was a 12-month period of data that was incorporated. And then for the other half, it was actually 3 years of data. In both cases, they're overlapping periods of by 6 months. The STS made that change because the volume of CABG cases has been going down. It used to constitute the vast majority cardiac surgery for all the programs, but there have been new innovations, more minimally invasive surgeries that are done. TAVR is something that's growing. And so in order to better statistically differentiate the programs, it's easier to have a higher volume of cases using a longer time period, which is what they did. The next one, the hospital's performance with respect to all-cause 30-day risk-adjusted mortality for isolated CABG cases. That's one where the hospital met the standard in 5 of the 6 periods, but it did not meet the standard in calendar year 2019, which is what led to the focused review. It was statistically performing worse than the national average. That focused review was conducted by a cardiac surgeon who is not connected to any Maryland hospital, who's board certified. We asked them to review the cases for mortality and look at whether the hospital's staff was responsible at any point during care, whether that was before the cardiac surgery, during the cardiac surgery, or post-operatively. Details of that focused review, as you know, are confidential. And so if you would like to talk about that more, we can go into closed session following this presentation. We did conclude that the hospital did take action following the high mortality rate in the time period before we conducted the focused review, and they were responsive to providing information that we asked for as part of the focused review. So we are still recommending that the hospital be considered in compliance with this standard. There have been a few reporting periods since then where the hospital is performing well. It is performing similar to the national average for other participants in the STS registry. The last standard that I want to mention is the volume standard. The hospital did perform at least 200 cardiac surgery cases in calendar years 2018, 2019, and 2022. The standard was waived in 2020 and 2021 because of the COVID-19 pandemic. In those years, the hospital did perform less than 200 cases, but still over 100. It performed 154 cases for 2020, and for 2021, it was 190 cases. That concludes my presentation. We are recommending that, next slide, that the commission approve Sinai Hospital for a certificate of ongoing performance for a period of 4 years. There are several representatives from the hospital here in person. Those include Dr. Peter Cho, the Chief of Cardiovascular Surgery, Dr. Henry Sun, the Senior Physician Executive for LifeBridge Health Cardiovascular Service Line and Director for the Cardiovascular Institute, Jill Love, the Associate Vice President for the Cardiovascular Institute, Ashley Spian, the Senior Director of Quality. And then we also have 2 remote attendees, Nitsa Santiago, LifeBridge Health's Vice President of Quality, and Dr. Charles Albrecht, the Chief Medical Officer for Sinai Hospital and Grace Medical Center.
Thank you. Any commissioners who have questions? Are there any commissioners that want to discuss the confidential part of the report in closed session? If everybody is satisfied, then I guess do I have a motion to approve the Sinai Hospital COP for cardiac surgery?
Motion.
Okay.
Okay,
I'd like to talk
you'd like
Oh,
to,
okay.
about it.
would like to go into closed session? Okay, can I get a motion to go into closed session?
So move.
And a second?
Second.
Thank you. All in favor? Are there
Aye.
any opposed? Why don't we go into closed session? Should we bring the representatives from Sinai with us?
And commissioners that are on the line, you'll be moved into breakout session 3. Stay with us momentarily while we execute on that.
There's two of us.
You want Sinai to come now, right?
Yes.
Representative, we can go next door.
Never know that geography. But a Haver's house.
Oh,
That's always.
oh, it's like. He goes, when he thinks I'm 3 a.m. Now where he goes to make breakfast. 5, 2. That was going in my head, but it might be moving. I think so. That's. guess she's telling everybody now.
She said she's gonna be the monitor for social security.
Oh, okay.
She's, I think the first 3 months.
Oh, the
You don't
first
wanna be
trimester,
on-
yeah.
Yeah.
Yeah. That's one. We don't look anything alike, so nobody really. We're different down, we see. Wouldn't be the help. What, people get them. Yeah, cookies, lots of cookies. Oh, it's the only ones here. Yeah, I know, it's like, it's good to double close in here.
But in fact, they do have to. They have to leave together.
If we don't leave, we'll have other dinner plans. Yeah. It's for Dash.
That's good. I actually put it in handy last night. We'll talk later.
Yeah, Commissioner Gilmore is with us. See Commissioner Gilmore. I don't see Commissioners Bandari, Boyle, or Ochikuchu. Oh, Kentucky. Might have everyone. Yep. Okay, I think we're back. First, I need to put some stuff on the record, what we covered in the closed session. We went into closed session under general provisions of Article Section 3-305B13 to comply with the specific constitutional, statutory, or judicially imposed requirement that prevents public disclosures about a particular proceeding or matter. Under Health Occupations Section 1-401, the proceedings, records, and files of a medical review committee are confidential. In addition, the commission is engaging in a quasi judicial function when it decides on an application for a certificate of ongoing performance under general provisions. Section 3-103, the Open Meetings Act does not apply when a public body is carrying out a quasi judicial function. The meeting was also closed under general provisions, Article Section 305B7 to consult with counsel to obtain legal advice. Purpose of the session, we discussed the focus review findings of the certificate of ongoing performance for cardiac surgery services for Sinai Hospital, and questions from commissioners about patient-specific findings, mortality rates, and other items in the focused review. The commission serves as a medical review committee when it or its contractor conducts a focused review, and these discussions about the review must be kept confidential. And commissioners also may, during the sessions, have questions for assistant attorneys generals about MHCC options. We have concluded the closed session. We're back on the open record. At this point, I'll ask if I can have a motion to approve the Sinai Hospital COP for cardiac surgery.
So
Commissioner Gilroy, thank you. Is there a second? Thank you, Commissioner Spooner. Is there any final discussion or questions for the commissioners? With that, I'll call the question. All in favor of the motion, say aye.
All right.
I can see the commissioners online. Are there any opposed? Great, the motion passes. Thank you to the folks from Sinai for coming today.
Very much.
I think there's nothing more we need from Eileen on this. Right? No. Okay, moving on to agenda item number 4. Thank you to the staff. That was, I think, moving back and forth and with breakout rooms. I think it was well done. I appreciate the effort putting into making that happen. During agenda item number 4, during the 2023 legislative session, the Maryland General Assembly passed Chapter 249 Health, Reproductive Health Services, Protected Information and Insurance Requirements. The law establishes protections for the disclosure of legally protected health information by electronic health networks and health information exchange entities operating in the state. The MHCC is required to develop regulations to support the law. Anna Gribble, Assistant Chief of Health Information Technology, will present the final regulations. Anna, you have the floor.
Thank you. Good afternoon, everybody, commissioners. Next slide, please. Next slide. Thank you. One more. Thank you. All right. So the 2023 law that the chairman just mentioned establishes protections for the disclosure of legally protected health care by health information exchanges, or HIEs, and electronic health networks, or EHNs. Legally protected healthcare is health information with the date of service after May 31st, 2022, that is subject to restrictions under the law and regulations developed by the Maryland Department of Health. Next slide, please. COMAR 102507 and COMAR 102518 are the regulatory frameworks to support implementation of the law. During the November 2023 commission meeting, proposed permanent regulations were approved after consideration of draft amendments based on an informal comment period, which was held last fall. Subsequently, the regulations were published in the Maryland Register on January 12th, 2024, and a formal comment period was open through February 12th, 2024. So to support compliance with the regulations, staff have been working with HIEs and EHNs to support implementation and provide guidance. So for the comments we received, staff received comments from HIEs, EHNs, professional health associations, consumer organizations, and healthcare providers.
13 organizations and 23 individual providers submitted 56 comments. And of those 56 comments, 30 were supportive of the proposed regulations. 9 comments suggested technical amendments, and I'll go into those in further detail in a moment. 17 miscellaneous comments were included, including considerations for MHCC, such as convening stakeholder meetings and providing further guidance. So after this presentation, my colleague Nikki Majewski will provide an update on how we are collaborating with our stakeholders to support implementation of the law. So other comments we received suggested changes to state or federal law, such as timelines and federal decision-making, as well as input on the potential economic impact. And there was a recommendation for the Maryland Department of Health. Next slide, please. So next, I'll provide further background on the supportive and technical comments. Thank you. So of those 30 supportive comments we received, most were from healthcare providers. Common themes include the law establishes necessary data privacy protections that do not exist at the federal level in a post-Dobbs environment. These protections provide confidentiality for Maryland providers and patients traveling to Maryland for certain services. And requirements on EHNs and HIEs offer reassurance to providers and patients seeking abortion-related care from facing retribution in the form of criminal or civil penalties in other states. Next slide, please. The following slides summarize the suggested technical amendments we received in the comments, as well as staff's response. Comments centered on the following. Include an exemption process in COMAR 102507 for EHNs, similar to the exemption process described in COMAR 102518. The staff does not recommend changes to the regulations since the law permits the disclosure of legally protected health information for the adjudication of claims, and EHNs are primarily supporting that form of transaction. We had a commenter recommend MHCC only withdraw an EHN certification if the EHN knowingly disclosed legally protected health information. For this one, staff also do not recommend changes to the regulation. The regulations already state that a person who knowingly violates the law is subject to a fine based on certain circumstances. So that language is already there. A commenter suggested regulations define when and how to collect and manage consent. And this is in reference to COMAR 1025-0709 and COMAR 1025-1802. For this one, staff does not recommend amendments as the law and regulations provide the legal framework for EHNs and HIEs regarding consent. I'll also note the processes and workflows to obtain and manage consent are handled by vendors in collaboration with their clients. We received a comment recommending MHCC clarify the definition of an HIE, referencing COMAR 1025-1801. And staff does not recommend changes absent changes to the statutory definition of an HIE, as that portion of the regulations references the statute. Next slide, please. The commenter recommended the regulations allow healthcare providers to have access to a patient's complete medical record in an emergency. And staff does not recommend amending the regulations. The law does not permit the disclosure of legally protected health information in an emergency. I'll also note Regulation 11 and COMAR 1025-18 allows HIEs to develop and implement emergency access policies and procedures and specifies the conditions for disclosing information in an emergency in alignment with state and federal laws. So there's language that exists in the regulations. And then a commenter suggested the regulations require HIEs develop compatible technology solutions that do not create undue burden on providers. Staff does not recommend changes to the regulation. So granular software development decisions are handled by vendors in collaboration with their clients. We do anticipate that the approaches may vary based on the different vendors, and we have been encouraging our HIEs to coordinate with their clients on their rollout. So after reviewing the comments and consulting with the AAGs, staff does not recommend any additional changes to the regulation and recommends the commission adopt the proposed amendments as final regulations. Next slide, please. So thank you, Mr. Chairman and Commissioners. That concludes my presentation. I'm happy to answer any questions you may have.
Put a motion on the table and then we can discuss and ask questions. Do I have a motion to adopt the final regulations, Comar 1025-18, Health Information Exchanges, Privacy and Security of Protected Health Information?
So moved.
Commissioner Jensen, do I have a second? Commissioner Douglas?
I think there are maybe two motions. If you go to the next slide, we may have them written out, both of them. Thank you.
So we'll consider this motion first and then we can go to
Yes,
this.
okay. So does anybody want to discuss the final regulations? But just to be clear, there were no changes. This is what we adopted.
Right.
Any questions or discussion? I'll call the question. All in favor of the motion, say aye. Are there any opposed? Motion passes. Move on to number 2. Comar 1025-18 Health Information, Privacy, Security of Protected Health Information is hereby adopted as final regulations. Correct. Oh, I'm sorry, though. So much process today. Do I have a motion to adopt the final regulations, Comar 1025-07, Certification Electronic Health Networks and Medical Care Electronic Claims Clearinghouses?
So moved.
Commissioner Wood, and I'll give Commissioner Douglas the second. Are there any questions about Comar 1025-07 or discussion? That I'll call the question. All in favor of the motion, say aye. Are there any opposed? We made it. Thank you all. The motion passes. Thank you. Agenda item number 5 is an update on implementing HB 812, Health Reproductive Health Services Protected Information and Insurance Requirements. The commission staff will highlight progress made by certified electronic health networks and registered health information exchange entities with implementing the requirements in Comar 1025-18 and Comar 1025-07. Nikki Majewski, Chief Health Information Technology, will present an update on implementation activities accomplished and underway. Nikki, you have the floor.
Thank you and good afternoon, commissioners. And thank you, Anna, for the presentation on the regulations to support implementation of the 2023 law that established protections for legally protected health information. Next slide, please. So as Anna mentioned, HIEs and EHNs are the entities required to develop the technical and policy solutions to parse and restrict from disclosure legally protected health information. Several entities have reported favorable progress in complying with the statutory and regulatory requirements, from updating their systems to block specific codes, educating end users of those systems in Maryland on new functionality to support the requirements for legally protected health information. Many HIEs need additional time to block text-based legally protected health information with more accuracy, such as the clinician notes. Planning has been underway to develop more enhanced functionality over time for filtering free text. Most EHNs operating in the state, as Anna had mentioned, disclose this information to a payer or business associate for transactions permitted under the law related to adjudication of claims. Next slide. So this slide shows the anticipated timeline to block legally protected health information based on vendors' implementation plans that were submitted earlier this year and the recent status reports. By June 1st, which is the compliance date in the law, about half will have the capability to suppress the required codes released by the Maryland Department of Health. For the remaining vendors, about half will be ready by the end of this year, and the other half will need more time beyond this current calendar year. The suppressing text-based information, as I mentioned, vendors are working to achieve compliance and meet the law's intent. Next slide.
Can I ask one question about the text-based? When we're talking about that, what level of intelligence we're requiring and filtering it. In other words, let me explain. Like you put a person on to read each note, you would expect that person with adequate training to always find the note, right, to understand it. You put a text machine on that just does a comparison of strings and you'll just catch certain keywords. And then maybe there's something in the middle where you have to have an AI that understands it. What are we requiring as a threshold on that text-based sort of free text field?
So we've heard it's a combination of obviously logic and human, involvement here. We are hoping they can demonstrate measurable progress to close that gap as, they look into this more and evolve their systems to develop that enhanced functionality. I think our intent is to try and suppress everything to the extent required by law eventually over time.
Right, but putting a person to read all these notes is also going to be highly expensive, I would think.
Good afternoon, Mr. Chair.
Good afternoon.
Commissioners. I think Nikki's answer is good, but let me build on that a little bit. Although I feel like I'm sitting on the floor.
I knew you were taller than that.
So you're absolutely right. Blocking text is not an easy endeavor. Remember when this begins. So it's June 1st. It's anything after May, the end of May, 2022, so June onward. So we're not looking years and years back. Some of the technology vendors are looking at more, as you mentioned, I'll call it AI specific opportunities. And other vendors are saying to their providers, look, Dr. Jones, nurse practitioner, if you're entering in a clinical record and you're talking about and making a note about legally protected health information, reproductive health for a moment, select this block, which means this whole note would be restricted from the exchange unless the patient gives you what they would call more specific or directed consent. So there's the ability to block notes at the provider level, and there's the technical level, which is going to take more time. Ideally, that's the end state because you get consistency, it's even. When you have individuals looking at it, they're always going to be making a judgment call. So the thing about the blocking of the text-based information is it's not an absolute. When you take the 19 codes that are in the Maryland Department of Health regulation, and you say we're blocking those codes, that's pretty absolute because you have a letter and 4 numbers and boom, you see it, it block it. When you deal with more text-based information, it's a closing of the gate, but it's not shutting it completely. Once more technology is brought into bear, perhaps the AI side of the equation, you'll get closer. But for now, it's directional and it's progress, but it won't be 100%, or won't be bulletproof. Use that language.
Thank you.
Yes.
Can I ask
Sure, go ahead.
related to that? So the most texting I'm aware of is between providers in the hospital, right? So nurses and docs are texting all day long. And how does that fit into this?
So let's just clarify. So now we're talking about actually using the text capability, say, of direct messaging, because the nurse or the doctor are talking about a specific patient. And so these text-based solutions that hospital use are encrypted, and they're not part of what's required here because the statutory definition talks about a health information exchange that meets that broad definition in health general. And there it talks about an electronic health network. That's equally defined in regulation.
Thank you.
But those texts wouldn't get into or distributed through the HIE, so there's no chance of a disclosure because.
The text message does not use the HTTP infrastructure for transmission. It uses an independent.
Thank you. Sorry, but back to us. I have to remember where you were.
No worries. The next 4 slides, I'll highlight some noteworthy achievements and activities underway pertaining to implementation. Next slide. The staff has worked collaboratively with stakeholders to develop regulations for EHNs and HIEs as required by the law. As you may recall, as Anna mentioned, the informal comment period last fall informed development of draft regulations, which were presented and approved at the November meeting. Proposed permanent and emergency regulations were posted in the Maryland Register earlier this year on January 12th and February 9th, and we do appreciate stakeholders' contributions during this process. The regulations are flexible to allow regulated entities additional time to implement certain requirements and request an exemption if necessary. We have convened 3 town halls, with the most recent one this week on Tuesday, which had almost 100 attendees. These events feature vendor success stories as it relates to progress in implementing the requirements, and provides a forum for vendors and others to ask questions about the regulations, which contributes to the development of implementation guidance for EHNs and HIEs. Next slide. The 2 implementation guidance documents were released earlier this year, and both were recently updated. These are documents that serve as a resource for EHNs and HIEs in the management, disclosure, and protection of legally protected health information. EHNs and HIEs have complied with reporting requirements and regulation. A review was completed of vendors' implementation plans and the recent status reports. Vendors who submitted implementation plans will be required to submit validation on April 1st, which is the next reporting requirement that I'll get into in just a bit. On the next slide, please. As for ongoing activities, staff plans to provide feedback on vendors' implementation status reports by the end of this month, and we are preparing to release guidance document with information on how to approach that validation reporting requirement due June 1st. This document will include guidelines for the reporting structure, as well as the process for submitting any request for an exemption. We will convene more town halls to continue discussions on implementing the regulations, and planning is underway for the next one in May. We are providing individual support to the technology vendors as questions come up, and we intend to continue to do this through the end of this year. And then the law requires that we either report to the Senate Finance Committee and the HGO Committee on implementation of the regulations on a quarterly basis for fiscal years 2024 and 2025, and we do continue to meet this obligation. Next slide. And lastly, here at the NHIE's request, we're participating in some discussions with their Maryland-based clients, engaging if we may need to intervene more regularly. We're also collaborating with civil representatives that are part of the HIMSS Electronic Health Record Association to advance the regulations. And this association has been very helpful in helping facilitate group discussions to learn more about compliance challenges and successes, and we will continue to engage them regularly. Next slide. This concludes the presentation, and happy to answer any questions.
Are there any commissioners with questions? Thanks. It's a very complete presentation.
Thank you.
Okay, we have our last substantive agenda item number 6, presentation on the Maryland Quality Reporting Consumer website. At our February public meeting, the staff provided an overview of the activities at the Center for Quality Measurement and Reporting. Today, the quality team will provide a brief demonstration of our Maryland Quality Reporting Consumer website, which is designed to increase transparency and informed healthcare decision-making among consumers and to facilitate improvements in the delivery of care in Maryland. Website demo will be given by the Quality Center staff, Courtney Carta, Chief of Hospital Initiatives, Symmetria McCammon, Program Manager. Okay, Courtney and Symmetria, go ahead. Got the
Thank
floor.
you for the introduction. We have the coveted 4 p.m. spot, so we will try to be as.
Until 6, whatever.
They even more coveted
That's what I
4:30
expect.
spot, don't I?
So this hopefully will be a pretty interesting, kind of a fun presentation. We have a lot of new commissioners who may not be familiar with our quality website yet. So we want to give you a quick demo just to show you all the types of information that we offer with our public reporting initiative. So next slide, please. Next slide. Okay, so this is just a brief org chart of our roles and responsibilities in the Quality Center. We are mandated to publicly report quality and performance metrics for a number of different types of healthcare settings. So we'll start at the bottom with Symmetria and I. We are primarily responsible for hospital data. Stacy Howes and Julie Beard are responsible for long-term care settings and commercial health plans. Mariama Simmons is responsible for outpatient surgery reporting. Up in the middle there is our methodologist, Teresa Brown. She does analytics across the different types of healthcare settings, and we each work with her individually. And then there at the top of the chart is our center director, which you all know, Teresa Lee. Next slide. Okay, so in order to be able to report all of this data, we maintain the quality reporting website. It's a comprehensive, user-friendly site. It provides accurate and timely information, and users are able to find, compare, review up to 5 facilities at a time to really be able to make informed healthcare decisions. It also promotes transparency and accountability among providers, and it's free and easily accessible online, and it's mobile friendly. So next slide. So when I talk about data, where does it come from? We try to.
Question. So when you compare costs, is there any way when you're comparing costs to factor in whatever discount is given to whichever healthcare plan you happen to be in?
So the costs that we report on are primarily hospital charges.
Right.
So that it comes from HSCRC.
Well, the hospital charge is the same, but then what I end up paying is different depending on which insurance I've got. So it renders the information largely useless to me when I'm trying to figure what's it gonna cost me.
But wouldn't you say,
Go ahead.
so for the consumer out of pocket, that typically would be the same regardless if you go to Hopkins University, MedStar.
Well, I would say,
I mean, but you have many, many different insurance products. You have high deductibles. You have,
I'm gonna push back on that because MedStar and, all the different systems negotiate their own reimbursement rates with all these different carriers. So it may or may not be the same. I mean, Hopkins might get a better or worse deal than MedStar.
So on the hospital rates, they would be the same. The cost sharing may change from the plans, but the hospital wouldn't necessarily know that.
Well, here's what I'm getting at though. We talking here, and I'll get off of this, right? But we talking here about informing consumers so that they can make, price-based decisions on healthcare. And you really can't.
You can.
Because this tells you what the rate that's set by the commission is, but it doesn't tell you what it's gonna cost me, because that gets filtered through my insurance plan, which is a different negotiated rate with each healthcare system, and then my different plan that I have. And if you can't build that in, and I don't know how you would, but if you can't build that in, then the information is really not useful to me in terms of where can I go, and if I'm gonna get my knee replaced, where can I go get my knee replaced and cost me the least amount of money, and then compare that to what's their hospital acquired infection rate, and then make what would truly be an informed decision. I don't think you can do it with this. So.
But I think you're halfway there. They do have the rates paid for the service.
The rates.
They don't have the cost sharing piece. But they have the actual hospital rates.
Right, so the hospital rate that gets charged to the insurance carrier, right?
it's paid by the insurance carrier.
The actual rate that's paid or the rate that is then subject to some reimbursement reduction based on the deal that the provider and the insurance carrier struck.
If we're talking about HSCRC hospital rates, they would be the same for everybody.
I think you're missing the point.
Yeah, so I'm with you though. The rates that the hospitals get paid by the insurance companies, it's one set, one payer, all payer, they get the same. However, depending on where you get your insurance, your employer's package that they negotiate with the payer, you will have different things included, excluded.
The
And
cost sharing changes, that's correct.
Right,
That's
so Mark won't know really how to compare. He'll know it's cheaper if he uses a system that his payer has an agreement with than not, right? Because in-network is always going to be better than out-of-network, but you won't know
Right.
how to be able to do the comparison
that you're looking for. You won't.
And I just put that out there as something for us to be, I don't think you can fix it with this tool. But when we have conversations about informed consumers making decisions based on quality metrics and price, I always keep in the back of my mind, that's not really possible with publicly available information.
There are actually, I mean, yes, you would need to go to your plan. But often it's not different under your plan, depending on, as long as you stay in network, you're in network, you don't, your costs may not change depending on how your plan is structured. But one thing that you see out in the marketplace, especially with the self-insured market, like large employers, and that's about half of everybody, is they will actually, they have incentive programs to use low cost, high quality providers. So there may be some use for this information for the consumer to figure out. You know.
But I challenge anybody here to go out and figure out what it would cost them to get their knee replaced. End of the day, out of pocket. Good luck.
Give us a couple weeks.
Closed session.
Well, and again, I'm not, this is not meant for you and for this presentation, but I think, and I'm gonna stop it on a bigger issue. That has to, in my mind, be part of our discussions going forward when we think about what could we do for the public. One, and number two, if we're asking people to make, economically rational decisions, we have to give them that information, and it's theoretically available. If you want to make a research project out of it and employ your CPA.
It's actually a little bit more available than we think. The Joint Commission has a standard that hospitals have to be able to tell people the cost of their care. And then there's this No Surprises Act, right? So you can't be shocked by your bill. And so a lot of hospitals today, when you make your appointment for your x-ray or whatever, they'll, after they look through your insurance, say, and we're gonna collect copay from you and it's gonna be $32. So you get some of that now more than we used to get.
But if you get your ACL repaired or
PCI.
a PCI, okay, or a stent or open heart surgery, it's not easy to figure out what that's gonna cost an individual person out of pocket ahead of time. And I would argue that it's practically, from a practical perspective, impossible for most people.
It's not good yet, but it's better than it was 5 years ago.
Yeah.
And so just to add, CMS does have a price transparency rule. Hospitals have to report on their website. They have to have a price estimator tool and they have to publish their charge master, which we know isn't super useful. But like you said, it's not there yet, but I think that they're trying to take steps to eventually get.
I'm not even gonna give them that, okay? I've been through this personally and with family members, and when the process starts, right? It's almost impossible to track even at the end of it, what it costs. And at the beginning, it might be better than it was, but it's still nowhere near where it should or could be.
So it does sound like Commissioner Jensen might need some additional training.
Yeah.
We can show you what we have. I think you're mostly right, but I think we can.
I'm very familiar with what's available out there through other through past experiences. So we can do that. I still think that it's not anywhere near as easy as it ought to be for somebody to figure out what it's gonna cost.
Well, I don't think anybody's going to take no, it's as easy as it ought to be side of that debate.
Okay, we'll say it another way. The technical term, I think, is it sucks.
It's a very complicated system.
Well, I'll just tell you, if you want to have your gallbladder out, if you do it in the Midwest, it's cheaper than the East Coast.
This is Commissioner Bandari.
Savings you fly out.
I have a
So-
question. Do we know how many people they use it? Nowadays, to see a doctor in a timely manner is a luxury. How many?
Website?
Yes, we do report monthly how many visitors go to the site. It's a couple thousand. I suspect a good number of those are the inside baseball crowd. people that work for health systems or work for insurers that are checking it out, but there are based on, we don't get email addresses, but we get the suffix of the email addresses, com, gov, org. And, you know, if it's an org or gov, probably most often not going to be a consumer, but someone affiliated with the health system or a government regulator.
Ben, even if they are looking at, I don't know how many will really go by the numbers because they want to see the doctor or the hospital who provides the services on a prompt basis.
Yeah, so I mean, this is a longer story. We probably should table that, but you know, Commissioner Jensen is partly right. But you know, there's another variable here, and that is that people don't shop for healthcare like they shop for shoes. It's my adage. And everyone wants, you know, some people want to buy shoes at discounts, some people want to buy them at, you know, Nordstrom's, but everyone wants healthcare at Nordstrom's, that the level of quality. And you know, the historical view is if it costs more, it's probably better, which has been, you know, kind of at least partially discredited, but people still look at price as high tied to quality. I think Jensen's right there. There's not good intelligence.
Thank you.
Awesome. Going to move on. So the data that we collect and report on, we try to get it from trusted sources. We may have some skeptics, and that's okay. But so we get data from various federal agencies like CMS or CDC, National Healthcare Safety Network. We work with other state agencies like HSCRC and the Office of Healthcare Quality. We administer some of our own internal surveys. We get data directly from health plans and other trusted sources. We really want people to feel confident in the data that we're using and displaying. So the data sets are updated at varying times. It depends on the measure. Some data are updated quarterly, others are updated annually. It really just kind of depends, but we do work hard to make sure that what we're displaying is accurate and as up to date as it can be. So we can go to the next slide. This is a screenshot of our homepage, and I'm just going to pause here. Share website. Okay, that went smoother than I. Okay, so I'm just going to go through a couple of features we have before I get into the data. So up here in the top corner, we try to make the website accessible. We have the option to translate the website into over 100 languages. We can also increase the font for those who may need it. You'll see this box here that says provider info. This is more of a technical side of the website. This is where we can house data or reports. It's not so much consumer focused, but it's a good resource for us when we communicate with. Up here in the top left, we have a couple of items, the long-term care planning toolkit, information about health equity, and then additional resources. And I'll come back to these a little bit later, but we keep these up here because we want them to stand out. We want people to be able to find it quickly. So if we scroll down, if you know what you're coming to our website for, we have this nice search box that you can use. And then directly below that, you'll see some quick links. We have a lot of information on price, whatever you're interested in. We've got a lot of different options for you to check out. We also have information for filing a complaint or if you need health insurance. These two are not necessarily within our scope, but we do get consumer questions, and it's very important. So we want to keep that front and center for people to be able to find.
Complaints good too.
OHCQ. And it's well, mostly, but there's a couple of different options.
Does it go to the difference? Like if you do insurance companies, it go to the MIA?
Yeah. I primarily send people to OHCQ, but there are other options. Yeah. And then we have some information on advanced directives and telehealth. So David's team has put together some really nice consumer materials for these options as well. But really, when we talk about the data for public reporting, it's down in these different icons here. So these are the various settings that we have at least some information for. And it varies a little bit by facility type. So we have a lot of really rich information for nursing homes.
But if we look at urgent care, this is more of a directory. So a couple of years ago, we were looking at urgent cares. There's not a lot of quality measures out there, but we also couldn't find just a comprehensive inventory of urgent care centers. So Symetria made one for us. So we've got all over 300 urgent care centers listed here. And it's basic information. It's their website, contact information, and where they're located. But for today, I'm going to use nursing homes because this is one of the more shoppable types of healthcare. Consumers really do have a choice when they're choosing nursing homes. It's also, we get a lot of hits from the website. This is the most commonly visited web page on our site. And so I want you to just put yourself in a consumer's shoes. If you maybe have an elderly parent or family member, and you need a higher level of care and you're interested in nursing homes, you could click there. And so it takes you to a menu of a couple of different options. You can find a nursing home near you. Maybe you have a nursing home in mind. Maybe you drive by one on your way to work and you want more information. Or maybe you need something, a specific type of service. You could start here. Maybe if you needed Alzheimer's care or dementia care, this would be a good place to start. These two bottom features are more resource intensive. So I'll come back to those a little bit later. But for today, I want to start here. I have a nursing home in mind. So you can click there, and this takes you to a page with all of the nursing homes in Maryland. So it's sorted alphabetically. We do have some summary metrics here. We've got some satisfaction ratings and some star ratings. All of these columns are sortable, but if you are looking for care for a loved one, you probably don't want to parse through 224 facilities. So we have some options up here where you can sort by. If you need, again, a specific service, you can check one or more of these. You can search by the name, you can search by zip code, you can expand out a radius, or you can search by county. So lots of different ways to look at the data. And so once you start to narrow it down, if you click on any of these names, I'm just going to click on this one. This takes you to what's called a profile page. So we've got some basic contact information, location information. This is a real picture of the facility. It's waterfront, it's lovely.
So like pictures of all the facilities?
Yep, Julie in the back collected pictures for every facility.
Well, the actual operator sends us
Yes,
pictures.
yes.
She doesn't go out and take pictures.
No, she did not. But she would if we asked her to.
Do that.
Bad job though. You need somebody to go take pictures.
Oh, exactly. We got a volunteer.
But managing these photos was a task that we're grateful Julie took on. So if we scroll down, we can find some more information. We just got some basic overview data here. We can find out about the star ratings, who owns it. We can see some configuration information, number of toilets, number of beds. We have some more information on cost. We know it's important how much is going to cost per day. And then if we keep scrolling, we actually get down to, these are those quality and performance metrics that I keep mentioning. So I'm going to just click on family satisfaction survey. I'll go through a couple more in a minute, but if we expand out this accordion, if you don't know what a family satisfaction survey is, we have this little icon here, and it will tell you that MHCC conducts a family satisfaction survey called the Nursing Home Family Experience of Care Survey. So these are results from that survey. And so this first measure is percentage of those who would recommend the nursing home. So we can see this particular facility, 96% would recommend it, the family members would, compared to about 69%, which is the state average. So definitely higher here. So if you are a consumer and this is important to you, you can flag it, and this will save when you come back to it. So I'll just scroll down a little to give you some flavor. We've got lots of different measures. We've got some staffing information. You can see how long the staff spends with patients. So lots of really good information. We've got federal quality measures, short-term or long-term care. So that could be under 100 days or over 100 days, depending on what you're interested in.
We also have some health and fire safety inspection information. This comes from OHCQ. So you can see when their most recent inspections were. You can find out more about the number of deficiencies, and then you can also compare that to the state. And then you can click down here if you want more explanation. We've got flu vaccination rates. So this facility does pretty good. Most of their staff does get the flu shot each season. It's much higher than the state average of about 74%. And then we've got available services. Again, if you need something specific, this could be a good place to look at. And finally, we have resident characteristics. So this is just kind of a graphic depiction of the makeup of the residents of this facility. So I'm going to go back. So once you sort of start to narrow down your search, you probably want to look at more than one facility. It's your loved one. You want to make sure that they're safe and you feel comfortable leaving them there, frankly. So I chose a couple that we're going to look at today. The first one is called the Neighborhoods at St. Elizabeth. So I can check this box. And then the second one is called Peak Healthcare at Caton Manor. So I'll check this box. And I can see I have 2 rows selected, and now I can click compare. And this brings up kind of a nice side-by-side view. You can choose up to 5. For today, I thought just 2 would probably be best. You get the gist. But so what you'll see on these compare pages is the same as what I just showed you on the profile pages. It might appear a little bit different for some sections, but I'll show you why in a minute. But the first thing I notice here is this red triangle. So I don't know what that means, so I can hover over it. And it says this facility has been cited for abuse or neglect during 1 or more of their last 2 inspections. So this is real data. And so this is really important for someone to know. So we try to kind of make that obvious from the get-go. So we can keep scrolling. You'll see on the right-hand side, there's more green, there's more hearts, there's more stars. So just at a glance, the neighborhoods at St. Elizabeth, their performance looks better. But you can see the deficiencies, again, the staff influenza vaccination rates that we talked about. You can compare the types of services offered, resident characteristics. And then we can keep scrolling. There's your price information. And then once we get into those quality metrics, I'm going to click on family satisfaction. And so if you recall, I highlighted these 2 measures earlier, and they are still highlighted because it's essentially saving it for you. So this allows us to look at peak healthcare compared to the neighborhood at St. Elizabeth compared to the state. So we can see that the neighborhoods at St. Elizabeth, they scored quite well compared to the other facility and compared to the state of Maryland. So for time's sake, I'm not going to go through all of these different options, but that information is available there. So once the user has kind of narrowed it down where they want to go, we also have a lot of different resources. So if I click here, this long-term care planning toolkit, this is a really nice kind of compilation of different resources. So we have the toolkit here, which we call it a brochure, but it's a long, comprehensive document. It includes lots of questions to ask, costs to consider, resources to call, places to check out. So it's really it's a really good tool. We also have checklists. So these are kind of short, sweet checkboxes, how to choose a different type of facility, and not just nursing home, different types of long-term care as well. Questions to consider, things to ask if you're going to visit a nursing home or facility. We also have different guides, we call them. They're again 1-pagers, 1 or 2 pages short, kind of fact sheets. Maybe you don't know if you need assisted living or a nursing home. So you could kind of go here and read about the differences. Again, we have more information on advanced directives. And then we have a financial planning calculator that we link to the AARP website. And then lastly, one more thing I want to show you, this is not enough resource material for you, we have more up here in additional resources. So we're gonna go to nursing homes again, because this is the setting we're interested in. And now we can find even more information just in a kind of a list format. Again, these are all short, sweet, 1 to 2 pages. They're all PDFs. Because what we've heard from focus groups is that especially older populations like to be able to print paper. They like to take it with them and have a hard copy. So we intentionally did that. And you can also hover and get a little bit more information about what you're about to click on. So with that, I think I want to just pause here, see if there are any questions about the website or anything else you maybe wanted to see before we we have a couple more wrap-up slides.
Commissioners, no questions? I think this is, especially if you're looking at the nursing home long-term care, it's an area people don't delve into very often in their lives. My question is, what percentage of the population knows when they have that one time, mom needs help to come here? Because it's a fantastic resource. I hate to think about people not missing it.
So sorry, I can't hear your question.
Yeah, how do we get to people when they have that one time they have to make this decision, right? For mom or something,
Right.
knowing, how do we get that in front of them?
So that's a great segue. I'm gonna turn it over to Simitria. And she is gonna talk about some of our promotion efforts because we know how important that is.
I imagine mostly this is used by people like my age.
It is, but
My mother won't be picking nursing homes.
I'm gonna stop sharing and
Voluntarily.
Madeline, if we could go to the rest of our slides. You can go to the next slide, Madeline.
Madeline's working on getting the website back up. The slides.
Next slide. Okay. Forward.
Next slide.
Right direction.
And backwards.
Okay, I'm just gonna go ahead and start. I can just talk to you guys. So now that you have a better understanding of our website's practical usefulness, I'm gonna give you a brief overview of our promotional strategy and talk about some upcoming activities. So just think promotion, 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 okay? All of the activities that you're gonna see on this next slide are designed to increase consumers' awareness and engagement or their interaction with our website. Thanks to our invitations from Commissioners Blake and Douglas, we recently had the opportunity to attend 2 community events, the Black Family Wellness Expo and the New Hope Church Blood Donation and Health Fair. These intimate events allowed us to have one-on-one conversations with consumers about the benefit of using the website. You see the lovely pictures from all of our in-person promotional events. We're also really excited to re-engage the healthcare community with our tailored website demonstrations, or what we call our lunch and learns. We've previously done this with hospital discharge planners in hopes of really reaching consumers at the time of decision-making. That's always at the forefront of our mind because that's one of the primary challenges with public reported websites is the consumers don't get the information when they need it or when they're making those healthcare decisions. But the opportunities with the tailored website demonstrations are not just limited to healthcare professionals. We also provide them to the general public, or specific organizations and groups with the interest in our website. And that's where we present to the librarians with the trainer, because they interact with consumers on our certain fronts. So we did a website demonstration for them and with different senior groups. We're also excited to explore the implementation of new mediums for disseminating the information, such as digital advertisements with the WMATA and MTA bus stops, and to continue with previous mediums such as digital ads for streaming services like Netflix and Hulu and Pandora. Next slide. So, will you be a Maryland Quality Reporting Advocate? Promotion is a big thing, and we can't just do it ourselves and within our center. So we always ask for kind of like surrogates with our partnerships with the Department of Aging, Maryland Insurance Administration, Maryland Emergency Preparedness Network. We share their content, they share ours. So I always invite everyone to follow us on social media. Feel free to like and share our content with your family and friends. I personally sent our Maryland Healthcare Commission Facebook page to like 100 of my friends, just because it's good information and it's not limited to one specific age group. But the more people that we get in Maryland, outside of Maryland, to follow our page, the more people will begin to see it because their friends are seeing it. That's just kind of how social works. So also you could take some material to your local pizzeria or community organization. I've taken our rat cards to my local like UPS shop. I've taken them to like Alito's Pizza. I'm like, hey, I order pizza every week. Can you leave these right here? They're like, sure. So just ask, and most of the time these organizations are okay with just you leaving a stack of cards. And then lastly, make sure that you tell a friend to tell a friend. Never underestimate the power of word of mouth. Yes. Next slide. Lastly, we're excited about a few upcoming initiatives, as Ben mentioned earlier about the House Bill 1051. We're collaborating with the Department of Health, Maternal and Child Health Bureau to develop that annual report card for birthing facilities in Maryland. And we're also in the process of revamping our health equity section of our website, where we'll update the directory of programs and include patient experience data by race and ethnicity. Next slide. That concludes our presentation. Like I said, you're always a friend. If you know an organization or even just a group of people, we have also been interested in talking to social workers, community health workers, maybe reaching out to student organizations that are upcoming health professionals to get them to know about the website on the outset of their career.
Do you have some cards you could give us today?
Some
cards
about the website? Yeah, we have some materials.
Great.
We will talk to anybody, so.
Thank you. Any commissioners with questions?
Yeah, so, we certainly welcome commissioners. If you have organizations you work with, Commissioners Douglas and Commissioner Blake gave us some invitations, and Teresa's staff was out there on Saturday a couple weeks ago and reported, that they had a really good outing. So if you have other opportunities in communities that you work with on an ongoing basis, you can share your credibility with us so that we can push our common initiatives. That's really great. Dimitri is also she's the primarily social media staff person, so she also posts on a variety of initiatives across the organization, including health IT, various other health planning initiatives, and some broader activities that are of importance, although not directly under our own authority, like Women's Health Month, etc. We try to keep people informed, but seriously, if you go to our website, go to our Facebook page, like us. We're always looking for new friends, and I'm getting dang tired of a friend telling me that his dog has more friends than our.
Not okay.
We're growing on all of our platforms. We're outperforming the industry in terms of our audience growth rate. So we're doing great.
Great presentation. A question. Are you on LinkedIn?
Yes, LinkedIn is actually surprisingly becoming like a big source of, like, we're becoming very popular on there.
So is it, save me searching around. Is it just under Maryland?
Maryland Healthcare Commission.
Your name, it's Maryland Healthcare Commission?
Mhm.
Okay. And then how small of a group is too small for you to come and talk to?
No group is too small. I will talk to one person. We love going to the community fairs, but I love the one-on-one interactions with people to be able to tell personal stories. I've used our website myself. I particularly like talking about the long-term care planning toolkit. My dad moved in with me like 2.5 years ago, and I tell people have a plan A, B, C, and D. I just had a conversation with a relative, like, how do you want to age? And she's like, I never thought about it. And I'm like, please tell me, because when you get to a certain age, I want to make sure that I'm honoring your wishes.
That's so good. Then I would add for commissioners, so when you first presented this plan, the idea, I was really stoked about it. And then while you had already been out at the meeting with Murder's House, I was so proud because the team represented so well with the rest of the team, just phenomenal. And what was different than all the other partners, we had a different slice of the data and information. So we had a lot of people at the table. It was really good. And then, of course, my nonprofit, we led a huge event. The rest of us said, yes, we would absolutely love to come. And so we don't want to be the best kept secret. We do some great work. And I personally, I think many of us have been affected. My parents, my mom and dad. I was a caregiver, didn't know it at 20, and learning how to get assets out of your name, how to get proof of Medicare, Medicaid, and full circle moment. Look where I'm sitting, right? And so even a lecture with students at Towson UMBC, telling them, you don't know this, but I'm giving you a gift that you don't know you need. Right, and explaining these stories, right? You hear it, and before you know it, you may be very sitting in a seat very much like me. So they've come on the commission. I think a couple of them not on mute, but I got on them for that. But they know the Maryland Healthcare Commission. They know the website. They understand the importance. And so I think if we just have a casual conversation, we're going to continue to grow by leaps and bounds.
Yes, and you can get some swag too, because you can be a certified Maryland Quality Reporting Tour Guide. So
Wow,
don't-
it's impressive. What do I gotta do to get that?
we design our own shirts and get them printed. So if you want a shirt, just let me know. We'll figure it out.
Yeah. Mark's in all the right places too. Know where he hangs out.
Our community.
Yeah, that's awesome.
So, this is your chance to say no or limit it, but I mean, transitional housing, halfway houses, churches,
Absolutely.
small groups,
Small,
like
we love to
my
talk to
office with all my employees.
Mhm.
All
Because
those you'd be okay with?
Said the same thing and they showed up.
And they still like you.
Yeah.
That's a.
They're good actors. They're good actors.
Okay. Look at,
Thank you very much. That's well done.
Well done. Thank you, guys.
Well, then you have the coveted 440 slot.
I have.
You got 7.
It looks really steepy right now, and I think that's gonna change though. We do just have one CON action scheduled for May, but I also think we're gonna be probably add a piece on price transparency, sort of show what's available. And we will have will we have any information on the June 1st implementation on the 812 requirements?
It's possible, maybe we put it as a bookmark and let's see if we can make it, let's see if that happen.
And hopefully by then, by May, we would have heard from CMMI about whether Maryland is successful in its application for the AHEAD model. And talk about that. Tracy will give us a complete update on all the legislative action. And we'll have a little bit more clarity on which one of the 3 trauma bills is actually going to be controlling. And we'll have a good idea on the amount of revenue that's going to come into the trauma fund. As I said at the outset, it's going to go from about $12 million today to about close to $30 million. And so the responsibility of the commission to award grants is going to grow quite significantly. To me. I want to thank all of the senators for the work today. David, Teresa, Winnie's group, as well as Ken. You know, everyone pitches in at these meetings. And sometimes you see people, sometimes you don't, but they're all working. And I appreciate everyone on the commission's attention throughout. I thought it was an excellent meeting today. Have a very nice evening and weekend.
Thank you, Ben.
Right, thank you.
Thank you all for your attention. As always, we managed to do 2 executive sessions back and forth. Good job. Do I have a motion to adjourn the public commission meeting?
No move.
Oh, no.
All right, second.
Second.
Third.
All in favor? I'm not hearing
Yay.
it. Thank you, everyone.
You did it.
This is all publicly available, right? That slide deck I can share.
Sure, absolutely.
Yeah. We're gonna get some,
Yeah, they're.
we're gonna get some activity.
Good.
Go team.
All right.
All right.
This is
I have to find out.